right, welcome everyone. Hope everyone's having a great morning. I want to welcome you all to this session of the 2024 Culture of Data Conference. Thank you all for joining us here today. It's day 2 of Culture of Data Conference. We are so happy to welcome you all back this morning, and we hope that you have found all your sessions and conversations fruitful yesterday. You're in store for another great day of programming, and we are excited to kick it off this morning with our Emerging Leaders Showcase. My name is Samantha Bertoman, and I will be moderating this session. We also have Alyssa Dalen here, who is managing the Zoom and making sure the tech is running smoothly. You are all muted now, but if you have a question during the Q&A sessions, please feel free to unmute. You can also use the chat box if you have any questions or need anything. If you are comfortable doing so, please go ahead and add your pronouns to your Zoom name by clicking the 3 dots on your video square and selecting Rename. I would now like to introduce the 3 sponsors of today's session. We would not be able to offer this programming and invite emerging leaders speakers free of charge without the support of these very important companies: Stedman Group, the Colorado School of Public Health, and Autonomy Group. I would like to start by asking Christina Abel from the Colorado School of Public Health to say a few words.
I'm Christina Abel. I'm the Director of Communications and Marketing at the Colorado School of Public Health. My pronouns are she, her. As proud partners of the Colorado Public Health Association, the Colorado School of Public Health is thrilled to be sponsoring the Culture of Data Conference Emerging Leaders Showcase for the 2nd consecutive year. At Colorado SPH, we hold data at the core of our endeavors, recognizing its pivotal role in driving impactful research, informing publications, and shaping our academic pursuits. Within our institution, data isn't just a tool, it's the very foundation upon which more than 60 programs and 5 departments are built. We embrace the vast landscape of big data, utilizing it to dissect trends, delve into research, and contemplate the broader public health implications that shape our communities. Yet, amidst the power of big data, we never overlook the significance of individual data points. Every data point holds a story, a narrative that, when woven together, forms a tapestry of insights into our collective public health landscape. It's these individual threads that allow us to discern patterns, unearth disparities, and ultimately pave the way for interventions that enhance both individual and collective well-being. With a thriving community of more than 600 students supported by 160 primary faculty spread across our 3 campuses, CU Anschutz, Colorado State University, and the University of Northern Colorado, the Colorado School of Public Health stands as a beacon of collaboration and innovation. We're not just a school, we're a triad of excellence, uniquely positioned as the sole school of public health in the Rocky Mountain region and one of the few tri-schools of public health nationwide. As emerging leaders, we hope you enjoy the conference and learn more about the important role of data in public health. Together, let's harness the power of data, not just as a tool for analysis, but as a catalyst for change. Let's explore, let's collaborate, and let's pave the way for a healthy, more equitable future for all. Thank you.
Thank you so much, Christina, and to the Colorado School of Public Health for your longtime support of CPHA and the Culture of Data Conference. I now have the privilege of saying a few words on behalf of our next sponsor, which is my employer, Autonomy Group. So you get to hear from me again. So at Autonomy Group, we are really excited to sponsor the Emerging Leaders Showcase. A little bit about us: we are a woman-owned and driven consulting firm. We partner with public health agencies, state and local governments, and communities. Autonomy works to address complex social and health-related issues with a unique focus on administrative solutions. We bring together collective technical capacity from a variety of partners under the Autonomy umbrella. We tailor our services to meet your specific needs and engage with you and communities to better and strengthen your work. Autonomy Group is excited to announce that this summer we are actually holding our first grant writing course. This workshop is designed to equip public health professionals with the fundamentals of grant writing. So during this full-day course, we will review the basics of grant writing and incorporate activities to apply new skills. Our course consultants have over 25 years of grant writing experience. So if you're interested in learning more about what we do, please feel free to check out our website, automygroup.com, which I will drop in the chat in just a second. And if you're interested in the grant writing course, please feel free to email me and I'll drop my email in the chat in just a second. Thank you all, and we're excited to be the sponsor. We're excited to sponsor the Emerging Leaders Showcase. All right. Now our final sponsor of this session, Stedman Group, has elected to not give opening remarks this morning, but we do want to thoroughly appreciate their sponsorship and continued support. They're a longtime supporter of CPHA, and we hope that you have the opportunity to say hello to them during your sessions and networking. We want to thank you so much, Stedman Group. All right, just rolling through the announcements this morning. All right, so this is the second year that we have invited the emerging leaders from the local public health community to speak at the conference. Last year, a few of our incredible CPHA board members came together to make this showcase a reality. The Emerging Leaders Showcase provides a platform for public health professionals who are early in their careers. The Culture of Data Conference and CPHA is proud to continue hosting the Emerging Leaders Showcase and celebrating the innovative work and talents of the emerging leaders in Colorado. I know that personally this showcase is near and dear to my heart, and I am thoroughly excited to be moderating today's session and excited to turn it over to our first presentation, which is titled Searching for Equity in the Absence of Quantitative Data.
Thank you so much. Share my screen. Okay, can everybody hear me? Can you hear me, Samantha?
Yes.
Okay, perfect. Well, thank you so much for the invitation. I'm very excited to share some of our experience. Today, I'm bringing the perspective of a small county on searching for equity in the absence of quantitative data. My name is Sara Torres, and I am a public health data analyst for Broomfield County, for the city and county of Broomfield. So a small outline, I will be first giving a little bit of context on Broomfield, and then talking about our community health needs assessment and our equity approach, what were our methods, the results, and a small conclusion. Hopefully by the end of this presentation, I will have provided a replicable path to reach communities traditionally underrepresented in quantitative data. So the city and county of Broomfield is a relatively small county. It's a city and a county. It's part of the 7-county Denver metro area with a total population of 76,000 people. And I'm presenting from the Public Health Agency. And in terms of population, Broomfield, while it is the 12th largest county in the state, it is the smallest in the metro area. So when we say small, that's a relative term. Here's the metro area, and for context, Broomfield is the smallest one, geographically speaking. So who do we serve? Our county is a community mainly made out of a white community, 74%. And our community is largely non-LGBTQ+, 85.4%. We have a growing population of 65 to 69-year-olds and a shrinking population of under 5s and 45 to 49-year-olds. The median income in Broomfield as of 2022 was $117,000. That means 2 adults would be making $28.25 an hour. When we look at Broomfield in terms of the federal poverty line, 7% of Broomfielders were living at 150% of the federal poverty line, which in the past years has stayed fairly stagnant. And it is the measure for a lot of services that we provide and that our partners provide. However, for us, an hourly wage that meets the cost of living in Broomfield calculated by the Women's Welfare University of Washington, the center, in 2022 would be an income of $104,293. That is about $24.69. So our margins are small for the self-sufficiency standard. We are currently on the process of doing the community health needs assessment. And this is made to fulfill the state level requirement. It allows us to dedicate resources and time to look at the current data, to understand where we're at as a county in terms of public health. And it's an opportunity to engage with partners and the community as a whole to learn about their needs and their perspective of our work. It helps determine our priorities for the next 5 years. And we're currently in the planning stages of the implementation plan. In Broomfield, we are committed to equity and telling the full story of our community. We use the Bar-High framework to ground our work, and this gives us structure for looking at our quantitative data, and it helped us drive categories in the response categories for a community partner survey, which is what I will be sharing today. So how do we find representation from minority populations? And this is just to give context for our particular county, we get a lot of suppressed data. The demographics categories that are not collected, it is very hard, for example, to find LGBTQ plus status currently. Also, the representative categories. We don't all fit the categories that we have, and it is a privilege to fit in those boxes. As a personal story, I am originally from Colombia, and when I have to fill out and I see the race and ethnicity is easy. I'm Hispanic. Whether I like it or not, that's the box I have to check. But then when I look at race, I was raised to not even think about which one is the dominant race that I should adhere to, and that I am a mix of them. However, a lot of surveys are requiring me to fill 1 or 2 boxes of something that is a construct I don't really understand or agree with necessarily, or even fit in. So the categories that we have are not necessarily representing our community. And then we have to rely on a few voices. And this is how we know we have these gaps. This is the sample size of the BRFAS survey. For Colorado, you'll see on the top, 10,476 individuals fill out the survey. For Broomfield, it's 149. In the back of your minds, remember that this is a place with over 76,000 people. We are telling the story of 76,000 people based on 149. And regardless of statistical methods and the magic we can do, we should always be wary of ground truthing our approach. We also know that the variance becomes really large, especially when trying to discuss the hard-to-reach communities. Where is reality when we're looking at data for our county? If we look at Colorado and we're trying to understand overweight or obesity, we can see that in Colorado, 50 to 65% of the LGBTQ plus population is overweight or obese. We can do something with that. But then when we're trying to plan interventions in Broomfield, we have a 30 to 87% of LGBTQ plus population being overweight. How do we plan and how do we think about approaches with such variance? This brings us to how did we respond to these gaps? So we decided to consult our community partners. Sometimes reaching directly to the community is not an option, which in this stage of our assessment was not. So we proposed reaching to our community partners to better understand the health issues that are affecting residents of Broomfield who are often left out of the traditional quantitative data collection. We reached out to the community organizations that are serving these communities and surveyed on what they thought is going well or is of concern. And we broke these topics based on all the quantitative data that we had, we broke it down into social determinants of health, health behaviors, and health outcomes. And our partners were able to rate each of these into not going well to going well, and it is not a concern. Our sampling method was a convenient sample of partners, organizations serving Broomfield working on health, other city and county departments. Communication tools that we used were constant contact, group email list, newsletters, direct invitations. And we sent this survey to over 100 organizations, and they were able to also identify if they wanted to be part of the next steps in the planning process. This was designed to help build the relationship and allow them to be part of the process. So in this survey, first, they identified the groups that they work with, and then they filled out a survey for each of those groups. Under each bucket, they got to identify how these groups that they serve were doing in terms of, for example, housing quality or affordability for social determinants of health, or physical activity in terms of health behavior, or mental health in terms of outcomes. Just as a reminder, each organization was invited to fill out the survey for each group they served individually. So if an organization serves 5 groups, then they filled out this survey 5 times. We had 32 individual responses, which represented 26 organizations, and we got representation from the population groups that we identified in the survey, as well as some groups that they self-identified. So the ones on the right are the self-identified, like veterans, those with food insecurities. And then on the other side, I want to point out that we do not have, for example, racial minorities, because that's something that in our quantitative data is one of the categories that we do have access to. And income is usually one of the requirements for people to access services. So it wasn't necessary to ask the question. So what did we learn? In terms of social determinants of health, we learned that housing quality or affordability is the most concerning issue for all populations. Healthcare affordability is important for people who are unhoused, non-English speakers, persons with disability, and the LGBTQ+ individuals. In terms of health behaviors, preventative care visits were important for non-English speakers. Alcohol use and substance use was important for older adults, youth and children, LGBTQ+ individuals, and those who are unhoused. And for health outcomes, mental health or suicide was important for all populations. But then we used this community partner survey to then turn it back to the general population to further prioritize, because we don't want to use only the voices of the organizations, but bring it back to everyone. So we did a survey for everyone, open in a platform of Broomfield where usually our community is used to engage. And then we brought to them these 4 priorities, asking them to further prioritize our findings. So after that, we've done our internal capacity assessment, we've finalized priorities, and we've done a presentation to our Board of Health. And now we're in the process of developing a plan. Our hope is now, with these results, is to go back to the community, particularly to those hard to reach groups that our prioritization comes from, and ask about the way that we're going to develop the plan, and ask specifically what they mean by those big topics. For example, behavioral health is a huge topic. So what part is it more important for each of the groups for us to help or to look into? And what do they want to see done, and how do they want it be done? The idea is it's a back and forth, it's a conversation that we want to have with minority groups based on the quantitative data, but allowing us to fill in the gaps and lifting up the voices of those who are harder to hear. So the key takeaway that I want everyone to have is that working with partners serving the hard-to-reach members of our community helps contextualize the conclusions drawn from the traditional quantitative data sources, and therefore it helps elevate the voices of all our community. Thank you all, and I am ready for questions.
Thank you, Sarah. For those of you who have questions, feel free to unmute or add your questions into the chats. Yeah, Dennis, thank you.
Hi, Sarah. Thank you very much for that information. Full disclosure, Sarah and I have worked together on some purpose data. So just putting that out there, I'd like to be transparent. So thank you again for putting it together. Looking back at the needs assessment for Broomfield, you mentioned it's relatively small, but it's also fairly dense. And how can you describe the process to those who are also working on their needs assessments and using the staff that you have on hand to do the community work that you've been able to do? Because it's not always easy when you don't have people that are either highly specialized or a large grouping of folks. And this is direct community work, super important, and it needs to be engaged with, but it can be a logistical challenge. So have you run into any of those logistical challenges, and what were you able to do to overcome them?
Yeah, so part of it is we leverage the relationships that we already had with the community. So a lot of the relationships that we had, when I said we, is the whole department was invited to invite their partners. So not leaving it to one of the people in the department is one of them. And the other part is accepting that it's not perfect, right? You do the best you can to reach out and then slowly try to figure out how to fill the gaps of those who you cannot hear. So I would say, in general, use the connections you already have and leverage those first. As you saw, we sent the invitation to over 100 partners. We had 32 responses, which is really good. We wish we had more, but consistency is always good. And then maybe give yourself a little bit of time so it's doable.
Makes sense. And be aware to also give yourself a little grace while you're at it, because
Yeah,
like you said,
absolutely.
it doesn't have to be perfect, it just has to start. And
Yes.
very grateful to hear how you started. Please continue, and you'll find partners as you grow. So thank you so much for your work.
Here we have Alexa who is raising their hand. Go for it, Alexa.
Sarah, so nice to see you here. This was such a great presentation. Thank you so much for sharing. My question is around your slide that looked at like financial, I can't remember right now what it's called. It's like financial liberty or financial,
Self-sufficiency.
yeah, financial self-sufficiency. What tool did you use? So in Arapahoe County, we've looked at the MIT, what's it called? The calculator, the living wage calculator, but I think you said you used a different one. Can you share a little bit more about that tool and why you chose to use that one instead of the MIT living wage calculator?
So we really like the definition. Sorry, I'm going to have to stop sharing for a moment just so I can see my notes on this. So we like the definition of a standard hourly wage, which is needed to meet the cost of living. And that was designed by the self-sufficiency standard at the Center for Women Welfare at the University of Washington. To be honest, I haven't looked at the MIT results. This just felt, what we really liked is you get to really choose what the composition of the household is. In our case, we chose a household with 2 adults, 1 infant, and 1 school-aged child, because it recognizes that it's different to have 2 infants than it is to have 1 infant and 1 school-aged child, or even to have 2 teenagers, right? The cost of living just changes, which is a nuance that is missing in a lot of the calculations of what the income is for you to access certain certain services. So we thought that was a very nice and nuanced standard to look into.
Yeah, I didn't know you could do that with that tool. You can't do that with the MIT calculator. So thank you for sharing this. I'm gonna definitely take a look at it because I might like that better.
Nice. I'm glad that it's a tool for you. And feel free to reach out. You have my email.
I do have a question. This is Lillian. Hi, thank you so much for a great presentation. And I do agree with the note about the visualizations. I love how they're presented. I also love how you brought in the data and are able to leverage that to speak to Broomfield, given that, you know, we might not be able to have access to such data locally. One of the things that I'm curious about, and then I like your point about the income and how it can be nuanced. And I wonder, you know, I haven't, have you had communications maybe with larger agencies, let's say like, what's that, like Medicaid? Maybe that might be out of your area, but, you know, something similar, I don't know, like, you know, accessing food stamps and those kinds of things. Because I know sometimes they have like standard levels they use for everybody, like across Colorado. And some people can be so stuck on that without looking at the nuances of the family. Or maybe that's a conversation that you could raise around those areas. I was just curious if you had that chance.
We haven't talked to the larger groups, but we have thought about it as a public health agents. We do provide services, and looking at this gap between the federal poverty line and the self-sufficiency standard, this is part of the ongoing conversation that we are having as the results of our health assessment come about, which is there's a large group of our population that might require some services that are not getting them. So I don't think that we've thought about going to Medicaid and asking them to reconsider what their standard is, but then we are considering our own standards and how we can assess those.
Yeah, thank you for that. And I was thinking more about a note of like having like, hey, or maybe looking at maybe who in your area, right, is identified in that group and maybe might need certain services. So not necessarily like, you know, but then kind of being able to communicate that to the larger groups to kind of look at how they serve the people in that region. Or maybe this is a start, right, having that information. But I just think it's a great conversation to start. Thank you so
agree.
much.
I totally agree. And I think it's a conversation, and at the very least, it's a conversation starter to have the information, and hopefully we'll start gathering information on who those individuals are. Thank you for your comment.
Other question? We could probably take one more question if anyone has anything. Thank you so much, Sarah, for this incredible presentation.
Thank you.
Awesome. Well, if anyone has any other questions, we will most likely have a little bit of time at the end to ask all the presenters some questions. All right, so thank you so much for that amazing presentation. I will now turn it over to our second presentation titled Colorado Pride Survey, a new tool to support 2S LGBTQIA plus data autonomy. Thanks, Oak and Sarah.
Sweet, thank you. Okay. Everyone can see my screen. Okay. Hello, everyone. My name is Sarah Ortiz, and I am presenting with my colleague Oak Slater on the 2023 Colorado Pride Survey, a new tool to support 2S LGBTQIA data autonomy. This survey is a volunteer project of the Gender and Sexuality Alliance Employee Resource Group at the Colorado Department of Public Health and Environment, which Oak and I are both part of. Terms 2S LGBTQIA plus is two-spirit, lesbian, gay, bisexual, transgender, intersex, queer, questioning, asexual, and other non-heterosexual and non-cisgender people. For this presentation, we will use the term queer community interchangeably with 2S LGBTQIA plus community. For this presentation, I already said that. On today's agenda, we will have Oak starting us off with an overview of the Colorado Pride Survey project. Then we will look at the design of the survey instrument, and from there we will dig into a few findings and end with any questions you may have.
Thank you, Sarah. The 2023 Colorado Pride Survey is a community-based survey which was conducted primarily at Colorado Pride Fest and also Juneteenth and Dragon Boat festivals. A total of 750 participants completed the survey. The survey was self-administered via a QR code obtained via paper materials such as the one pictured here. Participants were actively recruited by CDPHE employees throughout all three events. And I want to emphasize that this data is not intended to be representative or generalizable. Rather, the nature of the term community-based in this context means that by recruiting participants mostly from Pride Fest, respondents were highly likely to identify somewhere under the queer umbrella. And this meant that the likelihood that these respondents would recognize more granular subcultural terms would be much higher and see themselves in the subcultural terms. This proved to be true. For instance, almost 70% 70 respondents who answered the sexual orientation question identified as asexual, which was 9% of all sexual orientation respondents. So we'll get back to the purpose overall. The purpose of this project involved a few goals. We wanted to create a survey with affirming demographic response options that center the queer community's identities by including less frequently collected identity labels such as pansexual and two-spirit. We wanted to learn about evolving terminology for sexual orientation, gender identities, and other identity labels used by minoritized populations within the queer community. We also wanted to provide free digital health resources, such as how to obtain free COVID-19 and Mpox vaccinations. Finally, we wanted to create a way to promote community data autonomy and stay in touch with Colorado's queer community with the goal of sharing power and decision-making with survey respondents. So some background with how this was designed. The survey instrument consisted of 4 components: eligibility, identity, social experiences, and email opt-ins. The first 2 questions were required in order to screen out people under age 18 and people who did not live in Colorado. All other questions in the survey were optional. Next, the radically inclusive demographics section, which featured the commonly neglected or conflated data elements such as intersex status, romantic orientation, and relationship orientation, along with the traditional demographics such as disability, race, and ethnicity. We then included 2 sets of questions regarding respondents' comfort levels being out about their identity in various settings, such as their family of origin or with healthcare providers, with 1 question set pertaining to their sexual orientation and a separate question set pertaining to their gender identity. Finally, we included 2 opt-ins to provide an email address for 2 purposes. First, to receive information on those free health resources, such as another type was how to access free cervical cancer and breast cancer screenings in Colorado. And secondly, to be added to an email list for subsequent invitations for community input and to receive survey results. For today's presentation, we'll be highlighting our findings regarding the demographic data results, which illustrate how this community's identity label terminology changes throughout time and across generations.
Okay, thanks, Oak. Evolving terminology. For the survey question regarding sexual orientation among non-heterosexual respondents, those that were 35 and older were 1.7 times more likely to select gay as a sexual orientation option than those under 35 years of age. This association remains statistically significant when adjusting for race and Denver area residents. So this is interesting because me as an individual who is part of that queer community and under that 35-year age category, I've always viewed gay as an umbrella term. And since being gay is more accepted today than it was a few decades ago, it's fascinating to see that terminology sort of divide and see more terms be used that were initially under that gay umbrella, like bisexual, asexual, and lesbian.
And for the survey question regarding gender identity, among all 750 survey participants, respondents under the age of 35 were 1.9 times more likely to identify as non-binary than those age 35 and older. And you'll see that we did show that as an umbrella, partly for the sake of this is survey people are doing on their phones with limited space. But generally understood, non-binary also includes a lot of other labels. Other surveys might separate them out, but that's a ton of categories. So anyway, this association remained statistically significant when adjusting for race and Denver area residents. As a non-binary person over 35 myself, this validates my personal lived experience, as the term non-binary has become much more embraced both within and beyond the queer community within my lifetime. This demonstrates the need for continuous community-based data collection to understand how some terms may be becoming outdated and others are becoming more widely adopted. This matters because as time goes on, outdated data collection tools will not be counting people correctly and thus disguise real rates of disparities, both among and between various sex, sexual, and gender minority groups.
The data dashboards. So the primary purpose of these dashboards is to share with the survey respondents. This is part of what it means to practice data autonomy. So a group of CDPHE employees formed a Pride Tableau work group to determine the best way to visualize this data. And we ultimately decided to split the data visualization process into 2 phases, and I'll show you those now. So this is phase 1. Phase 1 is a viz that describes what the survey is, sort of what we just sort of went through with Oak, and it displays all the data points as a bar or pie chart. Please note that the data points that are displayed are not connected to each other in any way. It only displays how the respondents answered for each individual question. Okay, and then moving on to phase 2. Phase 2 of the data visualization project will dig more into the interconnectedness of the data. In this dashboard, you are able to select an option from each demographic and see how that respondent's comfort level is in certain social situations. Some of the numbers are also very small depending on the options you select when looking at different intersecting demographic groups, and this is due to the overall sample size. And then as Oak mentioned before, this was a community-based survey at Denver Pride, and this isn't intended to be representative of the entire queer community. This graphic displays one demographic profile at a time. For instance, if I were to select a bisexual woman who does not identify as transgender, this is how those respondents reported to the social experience questions in the survey. Please note that phase 2 is still being built and definitely needs improvements, but this is sort of the direction it's heading towards. And then just as a reminder, this is just looking at the respondents from Denver Pride and not a larger group as a whole.
Yeah, I'll clarify, piggyback on Sarah, that the Dragon Boat and Juneteenth respondents are also included in that, but overall, mostly we're Pride. Okay, so thank you for your interest and attention. Special thanks to our colleagues who helped with the analysis and visualizations we have presented. I think they're all here, most notably Lena Connectall, Hannah Peterson, Sarah Solberg, and Elizabeth Walker. Please feel free to email us with questions or feedback, and we also invite you to consider collaborating with us. And with that, we're happy to open it up for some discussion. Allison?
Hi, thank you so much for this presentation. I thought your identifying generational differences and how people are identifying was very interesting. And I guess I'm just wondering if there was enough sample size to look at the generation that was above millennials and see if there were any differences in how older generations were identifying.
Yeah, that would be interesting as well. Sarah Solberg did those analyses and tried out every single identity. We didn't do various other age separating out, mostly because the majority of the participants altogether were skewed younger. There was enough to separate just in half, I think, but there just wasn't really a lot of people that were in categories above that 35 to 44, I think. But in the future, the sample might be larger. Dennis?
Oh, thank you very much for that. And I'm going to speak for only a few of us, I imagine. Seems like no one cares about Gen Xers. I say that as a Gen Xer. So, man, always what it seems like it goes from boomer to millennial, but that's not what we're talking about. That's just a personal sadness. Thank you so much for that. That was excellent information. And actually, that led in from your last point. I would love to know more about the project sustainability and any future plans. I guess it's going to roll out maybe something that you have every year, something along those lines. How do you expand? What are your future thoughts?
Yeah, thank you. We love looking ahead, and we have, I just had limited time, so we just focused on these parts, but we have the panel, and that's huge. That was a big part of doing this, to stay in touch with community members. There were 350 people who consented to become part of the panel. Doesn't mean all of them will ever respond to us. That's fine. But that is something that we would love to focus on more, even to consider only doing the actual data collection every other year so that we can focus on analyses, and the analyses are meant to inform the design or topics of any focus groups or surveys that we would roll out and invite panel members to be a part of. But we also are in a place where sustainability means we did receive some funding for the next time we do collect data, but it's more to expand language justice and accessibility rather than FTE or kind of a bigger picture over years' time. It's not legislative funding or something. But that is, the department has invested now in Spanish translation, renting tablets and tablet stands so we can, accessibility if people don't want to use their phones, and also just printing costs and stuff. But anyhow, so we have some basic funding in that way, but it doesn't mitigate all the volunteer work we do. This is all extra work that CDPHE employees do, and we have so much fun doing it. It's energizing a lot. But so anyhow, call out for funding for any kind of, we want to compensate people for additional surveys and focus groups. We weren't able to have money to compensate people originally for the incentive, which we'd like to do in the future. But anyhow, so if anyone also already has funding for compensating people participating in focus groups or surveys, we're willing to design those, collaborate to design what those look like to benefit programs and other purposes, and just take advantage, you know, of having like such a concentration and diversity of identities that normally are just so hard to find in larger numbers. So it's on the horizon, but we're holding out. We don't want to ask people to volunteer free time. Sarah, do you want to add anything to that?
Well, we also have working on that partnership with One Colorado as well to expand to different prides across Colorado as well. So
right, yeah. I mean, they go to a whole bunch of prides. We started collaborating with the health equity director. They love partnering. They really are excited about the data. We collaborated with them. We do have a new draft of the survey instrument. We're just not sure if we're doing it 2024, 2025 yet for a few reasons internally. But anyhow, there will be, instead of those social experiences questions, there will be a social connectedness scale that's like a little more positive. And they'll be using that data as well. But they go to so many prides and they already have tablets. They're willing to just train their folks to, and they have such an amazing volunteer base that there'll be a lot more geographic diversity and what comes along with that. And they're willing to do that just as soon as we're ready.
Thanks, Oak and Sarah. You have quite a few more questions. You have Rebecca's hand raised. There's a couple in the chat. Maybe start with Rebecca and we'll go into the chat.
Yes, thank you so much for this presentation. Just a quick question in case I missed it. Do you plan to expand the survey to other parts of Colorado besides the places you already did?
Yes, sorry if it's confusing what I just said, but I was trying to say that that is the plan, and only through the help with One Colorado could we have the resources to do that. So they go to you know, northern Colorado, southern Colorado includes like Fort Collins, Pueblo, they go to Grand Junction, all these places, and they'll just do that on their own. We don't have to have CDPHE employees volunteering at those, which would be much harder. So I anticipate that we'll have a lot more geographic diversity the next time we collect data.
Thank you.
Claudia also has her hand raised. Want to go ahead, Claudia?
Thank you. Great presentation, and thanks for bringing awareness, as I put, awareness education through this, through this project. My question relates to the ones that you have been answering, because it seems that you purposely, which is fantastic, you went to Pride to start with this data collection. And people who go to Pride, they by virtue might be already more open and more willing to disclose their identity or their path or pathway or whatever is how they want to identify or call it. And with that, I was wondering if by virtue, I know that you did the under 21 and the generations, but you have a much smaller sample on the older folks who might have lived with this for longer years, but it was not accepted socially or not so open, and may have a different perception. And I was wondering how you plan on capturing them. And you mentioned the Hispanic population. I work with the Hispanic population and the Latino translation. Those who are in younger generation might not have the language barrier, but then you're going to have, and I noticed that someone says intersection, you're going to have intersectionality of various uncompounding factors, particularly as the population age. And I was wondering, I know that you mentioned at the very beginning, this is not generalizable, and absolutely is not. But on the other hand, on how are you capturing a population that may have other perceptions and you were not able to capture? Just an awareness point, or if you have it for the future.
Yeah, those are great questions, and I could talk about it too long for what the time we have here. But we do have that Spanish translation of the next survey, professional translation, the funding to pay someone to do that. But in general, with age, well, and there's also a Latin stage at Denver Pride, so there's a concentration, like hangout over there in that survey with more people. But so with age, it would really just have to be somewhere else that we would be able to survey more people of older age. And that would be, if we had really healthy amount of funding, we'd probably work with a center that has some programs for queer LGBTQ plus elders, and like, a lot of community connection there. So that would probably be a place to start and get their advice on how else to do that. But yeah, we're like really big surveys like the US Trans survey, they go to where the people are in all kinds of other ways and have like survey taking parties and with food and everything, and really their latest one with 92,000 trans people was just so much more diverse than the last time they did it when we couldn't do that. So I'll try to get to all these questions in the chat, and Sarah is welcome to jump in too.
Yeah, okay, I'm going to go ahead and read the first question then out loud for the recording. So this is from Lillian, who says, thank you for this presentation. I love the innovation about this project. I'm curious to know what your plans are going forward. Is this survey use planned to be extended to different contexts, settings, and groups/regions?
Yeah, I think hopefully I got to some of that earlier with some of the other questions, but I'm happy to, I know who Lillian is, and we're going to email already. I can get to that more with you, but I think the ones that maybe you haven't got to as much, I'll speak to groups since I haven't touched on that at all. And Sarah, jump in, please. But there's groups that there's hardly any data collection on, like the intersex community, and just gets conflated all the time with biological sex and things. And they have really, really complicated different kinds of issues going on. A lot of traumatization from birth, basically. So there's other elements, and there's just other groups that face different discrimination that is not, there's no protections on it, like people who are polyamorous and practice ethical non-monogamy, they have custody issues that their kids get taken away when they're divorcing, things, there's no protections on that for them, basically. So I would say groups like that is a priority, and like the part of the design of the second one is to have a little more branching for groups like that, and also including, someone else was asking about disability, and we don't know yet how to have like which branching questions for people who identify with a disability, but there's internal work going on of researching that for various purposes within our department. So I'll be tapping some folks to get their feedback on what other kinds of branching questions would be useful. But I did talk to the Interact intersex the biggest intersex advocacy organization. I consulted them with what other branching questions would be helpful. And so we have a couple of ideas for that.
I will go ahead and read the next question. You mentioned accessibility. Do you think that is a barrier to gathering accurate data on the intersection of disabilities and LGBTQ+?
Yeah, absolutely. I think that having the tablets is one thing. Another one is like there wasn't a lot of diversity with who was recruiting people, just based on who's like, I don't know, what I see is the majority of people working in public health around me are white, cis women. And I'm sorry if that's a huge generalization. That's like, that was the majority of who was recruiting. So I think when you have a more diverse set of people recruiting, obviously that makes a huge difference with who is inclined to do the survey. But the tablets is something that the concrete accessibility that we're doing, that also is in a context of people like don't quite trust like you doing something on their device that I think that that's invading their privacy or something. But yeah, we have a lot more to learn with that. And also like there's pretty high rates of people who identify with a disability who are also queer. There's hidden disability like neurodiversity, lots of kinds. Anecdotally know quite a few people identify as autistic who are LGBTQ+. There's a lot to learn about how people manage those disabilities and how chosen families like support them and accept them for that it's not a deficit, it's gift things. A lot more to learn. And I know you, Leanne, so we can talk again.
Thank you, Oak. We're going to do this one last question, and then we're going to jump to the next presentation. This is from Raymond. Did you identify a significance between those who identified as uncomfortable with healthcare providers and if they responded with an interest for resources for healthcare?
Yeah, we haven't got into analyzing who requested different resources very much. That's something, well, Sarah Solberg's here. We can chat about later, but she did analyze about healthcare provider context and who feels people's feelings on that. And there's definitely differences between different demographic profiles. And Sarah, do you recall, no worries if you can't remember the details right now, but do you recall any, I'm not sure if there were any statistically significant?
I can't remember that off the top of my head, to be honest. I am happy to follow up with anybody who'd be interested in seeing those statistical results. But yeah, I think Raymond's question is a good one, and I have written it down to look into. So hopefully we'll have an answer for you here soon.
I'll say there's a lot more research on that, and like, IRB approval type research, and not among that, I'd say from all my other readings and stuff that bisexual trans people are folks who have some of the worst, and a lot of people don't disclose their bisexuality to healthcare providers even, but they're really, there's not a lot of outreach or research on them in general.
Awesome. Thank you, Oak. Thank you, Sarah. All right. So thank you again for that amazing presentation. I will now turn it over to our final presentation titled Advancing Health Equity, Closing Data Gaps Through Partnerships with Latino Communities.
Hello, everyone. Can you hear me all right?
Yes, Janelle, you're good.
Wonderful. Well, thank you so much for the introduction, Samantha, and for this exciting opportunity to present here today for the Culture of Data Conference. My name is Janelle Martinez, and I am pleased to speak on behalf of my collaborators. And it actually echoes a bit of Sarah Torres's presentation earlier about really leveraging community relationships. So this is closing data gaps through partnership with Latino communities. A bit of background information. Hispanics and Latinos represent the largest ethnic minority group in the United States at nearly 20% of the US population and are projected to surpass 28% by the year 2060. Major health disparities affect Latinos, ranging from chronic disease such as cancers and cardiometabolic diseases to infectious disease as witnessed during the COVID-19 pandemic. Various social determinants of health impact the health of Latinos, who generally have worse socioeconomic status, live in food deserts and unsafe neighborhoods, and have decreased access to services. Additionally, Latinos face unique barriers to receiving quality health care due to lack of paid sick leave, lack of health insurance, base health literacy, and also face language barriers. So as we all know, data drives evidence-based practice. However, Latinos remain significantly underrepresented in clinical research and health databases. Because artificial intelligence can process large amounts of data and identify patterns to help systems make decisions, AI algorithms have the potential to address data gaps for traditionally marginalized groups. AI can recognize patterns previously undetected in these complex databases. They can superimpose health data with demographic and social determinant of health data to reveal previously unnoticed health disparities. And AI has the potential to detect Latinos at risk of disease before they manifest. However, major risks are associated with this technology, as we all know, as lack of diverse data, skills, and researchers risk misinterpretation and perpetuation of harmful biases. We also see that social determinants of health are not consistently captured, and the health information systems where AI is currently employed rarely collect demographic data beyond ethnicity, such as primary language, place of birth, immigration status, and length of time in the United States. Therefore, silos of meaningful data exist for historically underrepresented groups in which social determinants of health impact health outcomes. To mitigate these risks, the NIH's Aim Ahead program coordinates partnerships to enhance the participation of researchers and communities underrepresented in the development of AI and machine learning. And so it is through the support of this award and the Colorado School of Public Health that our Latino health class was given the opportunity to collaborate with a community-based health organization, Vuela for Health, with the goal of understanding data and data gaps that inform program decisions that impact the health of the Latino population around us. So Vuela for Health, our community partner, has been serving Hispanic communities for over 15 years, beginning in their local Denver neighborhood, and now has reached to rural Colorado. Promotoras, or community health workers, deliver evidence-based health education programs that have been linguistically and culturally adapted to better serve the Latino community. Vuela's programs include the National Diabetes Prevention Program, Community Heart Actions for Latinos at Risk, Familias Fuertes for building strong relationships within family units, youth mental health programs, and more. Outside of these programs, Vuela for Health links community members to important services for care. They also have a lot of great leadership programs and really support the community in ways that us researchers cannot. So our program data, our evaluation of their program data included data cleaning, coding, validation, harmonization, and integration, and statistical analyses were performed using standard statistical software. Vuela's data collection of who they serve was complete, comprehensive, and meaningful. 93% of Vuela for Health participants identify as being Latino, in which 78% is of Mexican origin. 67% of participants have lived in the United States for 10 years or more, and 80% of participants identify as being female. The average age of participants was 46 years old. Vuela's reach, as shown by the blue markers on this map, has expanded to impact Hispanics across the state of Colorado, including those who live rurally. It was found that the average family income for Vuela participants ranged from $30,000 to about $60,000 annually. 42% of participants reported having annual income below $30,000 for families. When surveying health insurance status, it was found that 36% 36% of WILLA participants maintain discounted health insurance, whereas a quarter of program participants do not have health insurance coverage. Despite the status of health insurance, all of the nearly 2,000 WILLA for Health participants in this database attend one or more promotora-led health programs. It was also found that 46% of participants said that their highest level of education is high school diploma or a GED, and 77% of participants primarily or solely speak Spanish. The collection of these demographic data not only speaks to the profound trust the local Latino community has in WILLA for Health, but it also represents unique data that is not necessarily collected elsewhere. For the 2020 US Census, there was nearly a 5% error in coverage for Hispanics, which was the largest error in coverage for any ethnic or racial group in the United States. Our analyses confirmed the positive impacts that these community health programs have on the health and behavior outcomes, as demonstrated by their Familias Fuertes program. Here, most behaviors are improved for caregivers, whereas nearly all behaviors were improved within youth participants. However, several inconsistencies and data quality issues were observed for other programs. For example, inconsistent pre- and post-program survey questions prevented our team from accurately analyzing their Confianza program, which is for building trust within family unions and solidifying some mental health. 72% of DPP participants experienced significant weight loss at the completion of the program. However, about 50% of questions in that pre-program lifestyle survey missed responses, preventing accurate analysis. So here's an example of that Latino adapted diabetes prevention program. The blank responses outlined in these black boxes could simply be missing data, or given the context of the survey, those answers could actually be indicative of a no response. So in the first analysis, unanswered questions were handled as missing data, and p-values are represented in black in this right-hand column. For the second analysis, unanswered questions were considered a no response, which increased the response n and often changed the p-value in the analysis, as seen in blue. So these red boxes highlight how this assumption skews the interpretation of program impact on lifestyle behaviors, from being insignificant to being significantly impactful. So these data quality issues can be traced back to data collection methods. And so we provided WELA with recommendations or solutions to the problems we observed in this important process for data collection. For the multiple survey formats, as they had paper and also online surveys, we streamlined their preferred data collection tool of the promotoras, which was actually paper surveys. For inconsistent questions, we cross-referenced across all surveys and we made them consistent for all programs. We also updated them to address changing societal norms. Free-form fill-in options were largely eliminated and replaced with preset choices to aid downstream data analysis. Likert scales were also added to transform all the qualitative data into quantitative data. To address survey fatigue and missing data, surveys were shortened and options to decline were added. We found that post-program surveys often do not have the same questions as the pre-program surveys, so we combined them into one for accurate pre-post comparison. We then emphasized training of the survey administrators and the survey takers. Additionally, we created a user-friendly and accessible data entry and management system. Data entry protocols were recommended to WELA to ensure data quality, avoid errors, and comply with regulations. The optimized data management tool we provided is Excel-based, which the promotoras preferred, and has predefined drop-down selections to reduce data entry error and fatigue, and also auto-populates data code that we created for quick downstream analyses. This tool also has the capacity to generate real-time data visualizations with a bit of training for the promotoras. So in conclusion, this project confirmed that CBOs are uniquely positioned to support underrepresented communities and positively impact health outcomes. CBOs supporting Latino communities do this by delivering evidence-based and culturally tailored health programs. They collect valuable data that can help improve social determinants of health that the Latinos face. However, data quality and integrity is crucial for us to access this. And this can be achieved by implementing easy-to-use tools for data collection and data management, and also by training community health workers on how to use them. And while AI and ML has the potential to address data gaps, major risks associated with this technology remain. Therefore, we recommend focus on equity and a human-centric, in our case, Latino-centric AI, so that this approach challenges biases and potential data interpretations. This approach, AI algorithms will continuously improve with human input. And so by empowering CBOs and cultivating partnerships, the community drives program decisions and public health decisions via data. And by implementing AI to close data gaps when needed, great strides can be made to achieve health equity for Latinos and other traditionally marginalized communities. There it is. And with that, I would like to thank our community-based partner for this project, Vuela for Health, and their directors, Diana Pineda, Tracy Pineda, and their team of passionate promotoras for the important work in the Latino community. This project was a class effort performed under the guidance of Dr. Claudia Mora and Dr. Patricia Valverde. And so I'd like to thank our instructors and also my fellow Latino health classmates here, specifically Alina Sanchez, for their hard work and dedication to this project. This project could not have been possible without the support of the Aim Ahead Award and also the Colorado School of Public Health, specifically the Latino Research and Policy Center, as well as the Centers for American Indian Health and Alaska Native Health. Thank you. And with that, I would also like to open for questions. Yes, Dennis, please.
Just before I do, Claudia, did you want to go first? I think Claudia was there. Okay, just double checking. Didn't want to step on anyone, and that would just be rude. So thank you so much, Janelle. This is excellent work, and very proud and glad to hear it. It fits perfectly with everything that we're talking about here today. So and throughout the conference. So please keep it up. I was going to ask about Vuela. They had, you said it's focused in the Denver community, but they also have reach outside of there to different rural communities. So one of the things we tend to talk about, because I'm a data geek myself, we of course will do our between group looking. So look for this group and that group. So in this case would be Latinos versus some other group. But we prefer to look within a group to find out how, however you define that. So within the Latino community, how are things faring? So one of the first thoughts was what the outcomes would look like within the Denver community, like for diabetes prevention program here compared to how it would work in a more rural setting. For some reason, San Juan Basin comes to mind, or somewhere down there. So do you think there's a place in a time where you might start to look within the groups and say, okay, here's our group, let's see how the community fares better or worse, and what other factors might be related to that?
Absolutely. Great question, Dennis. And I believe that is certainly future projections for Vuela for Health. How their program initiated was actually sponsored partnerships through, for example, the National Diabetes Prevention Program. And so they were able to access the local Latino community through that program, and they themselves did kind of within group measurements, and those outcomes have been published, and it was very successful. And so that's why they've been trying to expand their reach. And I can only assume, and my mentor Claudia can speak to it more because she actually works very closely with Vuela. But the success of that local program is why they have expanded their program and hope to have those community-led programs in other more or less dense areas. But it's also kind of reflective of the promotoras and kind of getting other communities on board to kind of facilitate those education programs. Claudia, do you have anything to add to that?
I was just putting a note because I don't want to rob you from your time. But yes, Vuela is expanding. We are I'm partnering with Vuela. I just put wrongly my email. It's Claudia, not I just typed too fast. But Vuela is expanding into rural areas more. I'm not sure what is the next phase of DPP for them. But they are expanding also and piloting, for example, one side project that I'm engaging with them and doing the evaluation for dyads of parents and youth in sex education and empowerment and mental health. So it is in their plans. Vuela has exploded in how much it grows and is also doing the trainer type of modeling for training others if they don't have the reach or capacity. So that is all in the go. Reach out and I'm happy, and I will put my email properly. That's not correct, but yes. We were trying to do all the data that they provide us, but they keep working on it. And this was last year's class also.
I'll go ahead and read the chat and so you can answer this question. So, oh, I almost missed Sydney's. Janelle, thank you for the great presentation. As a funder in the area, we are actively working to change the mindset about using data and evaluation for learning rather than strictly grant and funding accountability. I'm wondering how you fostered buy-in from the organization to dig into data and their collection methods. What challenges or pushback did you encounter throughout this project?
So I have to circle back to some of the curriculum that we have actually learned within our Latino health class is about the community-based research. And my understanding is that this, despite the long collaboration between the Latino health program and Vuela for Health, Vuela actually reached out to us because they collect all of this great data on behalf of some of their partners, but they do not necessarily have the training to kind of do all the data analyzation themselves. And so we really wanted to empower them outside of these partnerships to manage their data and do internal analyses if available. So that way they have a better understanding of which aspect their program is working very well and what aspects they can improve upon. So to answer data collection methods, they simply kind of continued with what the sponsored project outlined for them, and they just continued their data collection. We just went in and kind of audited their data collection process and management strategies, so that way within their own organization, they are empowered to do some of these analyses and change without that partnership. So honestly, that collaboration was kind of initiated by Claudia, so we didn't see too much pushback as far as being willing to provide over the data and willing to accept some of our recommendations. I would say kind of the language justice pieces, culturally, we're a little hard for the implementation side of things. So we kindly suggested some of these language justice pieces for their younger population who will, as discussed earlier, who have a little bit more understanding of social norms. And so we added some of those components for their survey takers. But as far as pushback from our collaboration, it was actually very, very open and well received, I would say.
So can I add to that, Janelle, if you don't mind?
Please do.
Yes, Vuela has a long-standing relationship with several of the faculty at the Colorado School of Public Health and with me. And we did partner last year also with other projects, and they saw how it was going with the students, so they were willing to open their doors, if you will, to us. The thing is that sometimes their concern was that and there was a question about funding. Funding drives what they collect and how they collect it and how they report it. And many times they are just the channel for data collection, but they have nothing to do with the evaluation. And they really wanted to own it and know how can they make an impact. So through conversations that we had and history that we had together, and part of my role has been that CBPR model that I'm also teaching the students in this class this semester. So because of that, we had a history and we had the trust from the community. So I already had the buy-in, and I was protecting the students, and I was bringing the students into this. So it was not that the students were knocking on the doors, because that relationship was already built. And I think that is important to say. Now, in other projects, I do get pushback from Wella for Help. The students didn't experience that. I do get the pushback, particularly when I'm the evaluator and I try to set up the questions that they are asking. If it is not mandated by the funders, they get a lot of pushback. Oh, this is just too much evaluation. This is just too much data. Can we change? And I'm like, well, these are validated tools. If you want a thorough evaluation coming from me, we are going to use these validated tools. Then we can adapt it. But the first round, so it is a dance. The first round is going to be set. It is a dance that is happening with SOMOS, this new program that we are doing together with DPP or with the other programs. They had the set questions, but they were complaining that for them was a black box because they just enter the data and they never see the results. So it was also a way for us to give back to them. And I'm sorry, I know that we passed the time.
You're good. We have time for one more question. Did I miss any in the chat? Let's see.
There's one from Shanna, I believe.
Perfect. Shanna asked, could you briefly explain what you've done to set up the survey data to have real-time data visualizations?
Yes, and that was actually simply an Excel tool where you copy and paste things from one box to another. We just didn't want to necessarily like complicate things because it has to be updated within real time. So we streamlined just an Excel, a very basic data management tool for Willa for Health, just because it's one, accessible, relatively inexpensive, and the promotoras were very well trained on that. So just very basic real-time data visualizations should they choose to copy and paste some of those bottom tallies into that graph.
And then if I may add, this was a short project. It was a class project, and the focus was Latino Health Project. And some of the students got the AIML scholarship, but not everybody. And not everybody has a data mindset in the class. So it was how to combine different skill sets, like in a real world team. Some people did the statistics and some others were more concerned about the social determinants of health. And parts of that we didn't even say. Many was, we did a walkability audit and try to understand the environment and the social determinants of health and then combine it all. We were just highlighting it for this purpose. Janelle was just highlighting the data aspects. So the next would be Tableau or a real dashboard or Power BI and integrating and doing the harmonization of the data and also integrating in something meaningful real time. We are not there yet, but with other projects, that is, this was a class project and the presentation of an emergent leader. I'm not justifying, but then if we had the tools and the resources, maybe if someone wants to partner, reach out and we could do it in other classes.
Thank you both so very much. And thank you to all the presenters today. All right. Well, I'm going to go through some of our closing announcements. Thank you all for attending today's session and for engaging in the question and answer portion. A few short announcements before you head out. Slides and any additional handouts the speakers have provided today are available on Sched. You will receive a conference evaluation form via email after the conference is over. Please, please, please fill that out. Even if you only attended a portion of the conference, it's really helpful for our planning committee for the next year. There will be a raffle for everyone who does complete the survey within 2 weeks, and you could be one of two $50 gift cards. And thank you for joining us for the Emerging Leaders Showcase. We will now have a 15-minute break before the next concurrent session begins at 10:30. There are 3 sessions to choose from at that time. You can see the full schedule on the Sched conference website. Thank you all. It was wonderful to see you all, and thank you, Emerging Leaders, for your presentations today. They were incredible. Have a wonderful quick break, and we'll see you back in 15 minutes.